or Monday's session should be up on YouTube, FYI, in case anyone would like to revisit that. 2 hours of fun. So let's share geriatrics. So the majority of the patients that you actually end up seeing, or end up probably for the most part end up being geriatric patients. Um, Collectively, the geriatric group is growing very rapidly, right? And like the baby boomers are all moving up into this quote unquote geriatric region. Geriatrics are patients who are 65 and older. It is, in fact, the fastest growing age group in America. Um, as I said, the baby boomers, right? They're collecting, they're getting that AARP stuff in the mail. Um, so they're starting to, kind of change the needs for healthcare in this country. A lot of things like assisted living and nursing homes and stuff are kind of booming because you have this huge group of older population who require assistance. As I said, almost more than 40% of our responses are for older adults, and this can range from medical complaints, syncope, cardiac arrests, stroke, and even just stuff like trauma too, right? A lot of geriatric patients are experiencing trauma as they start experiencing equilibrium issues or dizziness or high blood pressure and stuff that can cause them to cope traumas, or they're driving and they shouldn't really be driving anymore. It's all over the place. So you're going to see a wide variety of things. While we're looking at the emergency side, a lot of the time that we don't really see is the other end, right? So you bring a patient to the hospital, they're having a stroke, and they never regain, perhaps they never regain full abilities. They start to end up creating a drain on the system, right? They start increasing healthcare costs. They start to require, assistance in living costs, and stuff like that. There's this huge push in this movement in the United States as well as other countries for caregiving at home. Um, while this is great and it reduces a lot of community acquired pneumonias and UTIs and overall geriatric abuse because nursing homes are horrible, um, this now puts this strain on family and caretakers. Okay, we'll talk about this a little bit when we get to special needs abuse. There's a huge group of people, of caregivers, adult children and stuff who aren't equipped to be caregivers, and might actually end up creating a lot of abuse and neglect issues for those older adults who are relying on them. Um, so chronic illnesses, right? They tend to pop up and create a lot of problems as well. Um, we talk about, oh, we need these solutions for long-term care. In the grand scheme of things, there's not a lot of good solutions for this right now. Like, we don't have the infrastructure in this country to really provide um, proper help for a lot of people. The other issue is well, not issue, but like they're trying. There's some things that they're attempting to put into place. There's if you are a primary caregiver, the state, I know it's at least New York State, I don't know if it's a federal program, they'll pay you to be a caregiver. Okay, so if you are no longer working or no longer working as much, they will pay you to provide care to an elderly loved one. So they're trying to get these programs in place, but it's too little too late. They weren't ahead of the curve for the baby boomers. A lot of legal and ethical issues surrounding the geriatric population that we see in regards to as providers. So advanced directives, I think we are all relatively familiar with the DNR and most. But the problem with some of the advanced directives is that they're put into a living will or a durable power of attorney that we cannot recognize um, in the pre-hospital care setting. That doesn't mean that if you have a geriatric patient in cardiac arrest with a living will who desires no resuscitative measures to be taken, that you can't get on the phone with medical control and explain that situation to them. But there's it's some complications there that arise. Another problem is like the autonomy of the elderly. You know, you really should go to the hospital. You really should go to the hospital. We start to bully people into doing stuff. And even if they don't necessarily want to, some people just want to kind of be left alone. Sometimes we have to respect that, and sometimes we have to push. Okay, so it's kind of you're walking this fine line between, you know, respecting someone's autonomy and their self-determination and trying to present them with the information that, hey, you really should go to the hospital. Hey, you know, there's really things that, you know, can be done to make you feel better, or, you know, you're in a really serious situation right now. You need to go to the hospital. Um, I talked about this last night in my EMT class, actually, which is kind of funny. So in about 2014, with I believe it was 2014, with Obama's Affordable Care Act, one of the less spoken about um, components of that Care Act was trying to make hospitals more accountable for their actions and their treatment of patients. So patients who were discharged and then readmitted within 30 days, they would not pay the hospitals the full amount of their care. Okay, so like you got like a bit of a discount because the hospital didn't do right by you in the first place. So they, you know, we're trying to hold hospitals accountable to make sure that when they discharge patients, they were a-okay. Like they weren't going to be back in the hospital. It's nice to not have to worry, you know, about, you know, am I going to get sick again? But there's some patients with those chronic illnesses, you know, who maybe aren't taking care of themselves that you can only do so much for. About 17% of our patients that we see are repeat transports. And by repeat transports, it's that 30-day window. As you get older, um, you will have a predictable decline in your, or a relatively predictable decline in your overall well-being. If you take good care of yourself, you know, eat your vegetables, hydrate, exercise regularly, a lot of this isn't necessarily going to happen. You can delay a lot of this because muscle tone is actually a huge component of your overall well-being. But once you start to hit 30, hi, anyone else over 30, welcome. You start to have this decrease, right? You start to be less able to maintain that healthy, you know, well-being because, you know, maybe, you know, it's a lot of it's a Western lifestyle also. The problem is once you hit a stressor, okay, it could be a broken hip. It could be a severe illness, a stroke. Okay. It starts to knock you down faster. Okay. Once you start hitting that level of frailty, you start to become dependent, right? That starts to increase your likelihood that you're going to be depending on other people for your health and well being. Overall, predictable changes that do happen is when you start to have decreases in your respiratory system, right? Decreases in the functionality of it. So your lung capacity starts to decrease. Your chest wall compliance, right? That elasticity starts to decrease. Your lungs aren't as elastic either. All those muscles in between, like your diaphragm and your intercostal muscles, start to get weaker. And your alveoli start to kind of get a little less robust. Okay, so overall, you see that, you know, it's just a generalized decrease in well being. By 75 years old, your vital capacity will potentially decrease as much as 50%, which means, you know, those 75-year-olds who are out there still running marathons, they've done a good job of keeping themselves in good shape to avoid a lot of those issues. Um, Other problems that start to increase, right? So that the health of your lungs, right? These 75 years of breathing in pollutants, right? People who live in a city are more likely to have lung issues, respiratory issues than, you know, people who live outside of a city. Right? Pollution does a wild amount of damage to your lungs. Smoking does a huge amount of damage to your lungs, primarily that cilia, right? Those little tiny hairs on the inside of um, your respiratory tract that start to move mucus up. As those start to get less compacted or less frequent in the airway, it you have that mucus kind of sitting there, and then you have on top of that a diminished cough reflex. So you have an increased risk of choking and aspiration. Aspiration pneumonia takes a lot of the elderly people out. Um, as you get older, your heart also experiences a number of changes, while you might experience some blockages, excuse me, which will reduce your heart functionality. One of the good things that does happen with your heart as you get older is it creates what's called, um, oh my God, the word is gone. Collateral circulation. There you go. So that collateral circulation will kind of bypass some areas of blockage. So if you do have an MI, the older you are, usually the more likely you are to have a less damage to the heart muscle because that, that the collateral circulation has gone around where that blockage is. Um, you also do tend to lose a lot of the ability to raise your heart rate. Okay, this might be due to medications. This might be due to just the natural changing of your heart, right? The weakening of that electrical system. Um, the left ventricle becomes a little harder, a little stiffer, right? This high blood pressure starts to become a thing. You don't respond necessarily as well to catecholamines, right? That epinephrine, like that fight or flight response. And then you have a higher incidence of arteriosclerosis, right? That fat lining the blood vessels that can increase the risk of an ischemic event. Other things that happen, right? The electrical system starts to change. Uh, Patients will start presenting with AFib, right? More commonly as a chronic issue. Bradycardias or heart blocks pop up. Most of the time, bradycardias and heart blocks could be due to medications. They could be due to an ischemic event. And then you have sick sinus syndrome, which is basically the heart just starting to kind of shut down. Right? The electrical conduction system just isn't functioning well. The SA node is not functioning well, and alternative pacemakers start to take charge. Um, Unexpected stress can trigger a sudden cardiac arrest because there's a number of things that are going on in the heart, right? You have potentially some ischemic changes. You have hypertrophy secondary to high blood pressure, that left ventricle having to work harder, coronary artery disease, other hemodynamic changes, right? Because a lot of times as you get older, you're not just dealing with one issue, you're dealing with, multiple comorbidities. So as they start to play upon each other, it makes things overall worse. As you get older, the blood flow to your kidneys starts to decrease, right? So your kidneys are contribute to potential high blood pressure. As the blood flow to the kidneys decreases, the blood pressure they call for higher blood pressure, which starts to release antidiuretic hormone into your bloodstream, constricting your peripheral vasculature. Um, so you have the potential of the kidneys contributing to high blood pressure. The overall mass starts to of the kidneys start to decrease, so they get smaller, which means they don't function as well. And then that means that there's also other issues. UTIs are very, very common, especially in the elderly group. Uh, Renal failure happens a lot. Sometimes even dehydration can put elderly patients into renal failure. Trauma, always a possibility. Um, a number of other things, right, that can cause problems with the kidneys. So as kidneys start to lose the ability to concentrate urine, right? So you want to actually make urine. You have increased number or increased amount of waste products staying in the bloodstream as they can't concentrate urine very well. There's a hard time maintaining the appropriate amount of sodium, right? So you see a lot of elderly patients have hyponatremia, right? Because they're just urinating out that sodium. They aren't able to maintain that homeostasis as well. Um, this also means that sometimes they're not able to get rid of some of that water that they need to, right? We see a lot of elderly patients on different diuretics to try to help, get that fluid off of them because it starts to build up in their ankles or their lungs, depending. Um, you, the filtration isn't necessarily good, so that kind of speaks back to concentrating the urine and sodium and all that stuff. One of the most common things that you will see in the elderly population is adverse drug effects. Okay. So, one of the questions that I usually ask when I'm dealing with an elderly patient is, have they changed your medications recently? Or has there been any recent change? Have they increased a dose, changed meds, anything like that? because a lot of times patients they'll give them a new medication and it's interacting with another medication that another doctor has prescribed, and all of a sudden they don't feel well, or they put on a more potent blood pressure medication that's causing their their blood pressure to completely tank. So there's a lot of different issues that can kind of arise from being on a long-term chronic medication treatment. Um, a lot of patients also are not particularly good at being compliant with their medications. Okay, they might take it one day because they have a headache, so they know their blood pressure is high, so they take the medication, but the next day they don't because they feel fine. Doesn't mean that their blood pressure is not high still, and that they're not doing damage to their body by not being consistent. So there's a lot of things that can happen. Overdosing is very popular, also, or possible. Also, you have patients who, excuse me, or maybe prescribe pain medications. Or I had a lady with a fentanyl patch on once that it just took her down, because they don't have, elderly patients don't have as much subcutaneous fat. So without as much subcutaneous fat, you lose the predictability of medication patches and how much medication they're going to administer to a patient at a time. So, you know, it's a great idea. It's a great concept. You're going to give a little bit of medication over a extended period of time with this medication patch, but sometimes you can completely knock somebody out on their ass. Um, Other issues, right? Some drugs really need to be used cautiously in the elderly population. If you look at your GOPs and SOPs, there's actually like cardizem, for example. Okay, is have a patient with certain medication or certain comorbidities, you want to reduce the dose. There's because of the overall changes that occur with aging, your kidneys aren't working as well, your liver isn't working as well. If some of these medications are, excreted by the kidney and the liver, you don't necessarily want to give them these massive doses that you could safely give to a patient who's younger and has more healthier organs. As you get older, your neurons start to decrease and your brain does start to shrink. Okay, so this is why trauma in elderly patients is so can be so devastating but missed, because you have extra space in the skull. So those signs and symptoms of brain bleed might be delayed in actually showing up, okay, because they have just more space because their brain is smaller. Intellectual functioning can deteriorate. There's plenty of people who are super sharp still. So this is not necessarily, I guess, a tried and true fact. Then you have patients who, might have Alzheimer's that started when they were really young. So sometimes it's just bad luck of the draw, bad genes, that set you up for intellectual or neuro failure. Other problems with decreased cerebral blood flow, right? Just because you have coronary artery disease doesn't necessarily mean that you don't have artery disease everywhere else. Okay, the plaque buildup doesn't just say, "Ooh, the heart, lovely place, I'll live here." It can go all over the body. So that means that the places in the brain can experience similar decreased blood flow. Sometimes you'll end up with getting that nice collateral circulation as well, but sometimes it doesn't have the time to do so, right? Sometimes you'll have a catastrophic event like a stroke, that before that collateral circulation can be established. Um, Impulses, the electrical impulses, right? So we talked about how as you get older, you lose a lot of sodium because your kidneys can't concentrate urine great. One of the side effects of hyponatremia is a diminished ability of your nerves to send electrical impulses, right? Your nerves rely on sodium. So if you're sitting in this hyponatremic state, you're going to have, neuro effects, noticeable neuro effects, which means that, you want to take into consideration that, like, hey, maybe this patient crashed their car because they are hyponatremic, or maybe their reflexes have slowed down to such a point, excuse me, that, they weren't able to respond appropriately to, a hard braking, or, someone swerving in front of them. Other things that also change, right? Your visual acuity, your eyes get worse or your eyes change. So I can't see distance very well. But as I get older, there's a possibility that that's going to switch and I won't be able to see up close well. Okay, just you're changing in your eyes. Your hearing starts to get worse, especially if you have a long childhood of listening to very loud rock music, okay? And your sleep patterns change, right? Usually, as you get older, or as you're younger, you have that kind of 8 hour block of time where you have those hour and a half periods of REM sleep. As you get older, that your time of being in bed shifts a little bit, okay? The amount of sleep that you need shifts. This is why the elderly like to take naps, okay? Because that's just how their sleep cycle starts to change. Other things that will impair the mental functioning is all sorts of medications, right? They can cause a lot of like mental fog, acidosis, alkalosis, hypoxia, any sort of organ failure, okay? All of those things can contribute to that patient not being as cognitively functional as you would otherwise expect. As you get older, your musculoskeletal system also changes. Your muscles start to shrink. Okay, so if you were not a professional bodybuilder beforehand, you're definitely going to look kind of scrawny as you get older. Um, your bones will weaken, right? You'll seep some calcium out. Okay, the spine can start to um, curve. And this picture right here is kyphosis as the discs start to get thinner. And gravity takes its toll. You'll see a lot of overall height loss. Okay, so especially like women for some reason, like they start off short and they just get shorter. I'm looking forward to being a solid 4'11" by the time I'm 80. I'm just gonna get tiny. It's gonna happen. Shrinking. Um, so other things, right? Your lean body mass, your body composition will change. So you will have an increase in body fat and a loss of muscle overall. Body water, right? You don't hold on to water as well. And those two factors will really impact how drugs are dosed. Okay. This is why, we just kind of do a widespread medication, dosing for patients, but the elderly can really require a lot of tweaking for their medication to make it work. Okay, body fat will store medication. So even if they're taking a small dose, that body fat will hold on to it and like gently excrete it over a period of time, increasing the effects of that medication. Your immune system doesn't work as well. It's harder to keep patients in that happy internal homeostasis phase, right? That's why grandma's out there in a 90-degree weather with 4 sweaters on. Um, and nutritional disorders, dentisha, your teeth, will create, or having good teeth will predict your life expectancy. Okay. Your ability to chew makes a huge difference. Okay, that's why a lot of elderly patients will have issues if they can't chew food, they don't eat food. Your taste buds start to deteriorate, which means that food doesn't taste as good. So they won't eat as much. All right, they don't want to eat because there's no joy in it anymore, or it's hard because they have poor fitting dentures, or they're choking because they're not chewing well. So it's just a lot of things that kind of start to compound. When you are assessing your geriatric patient, you want to make sure that you get a good picture of what's going on. These patients can be historic, like their history can be very complicated. So you want to try to get a good idea of what their comorbidities and their chronic issues are. Acute on chronic illnesses pop up a lot, right? You have a patient who has a history of COPD and a history of CHF, and right now they're breathing absolutely horribly, right? Or they can have heart failure with APE on top of it. Okay, is usually what you kind of see, or high blood pressure, kind of creating all sorts of other issues. Um, as your neurological system kind of declines a little bit, the pain responses or the acknowledgement of illness, right, or not feeling well, kind of gets diminished as well. So you won't, elderly patients won't notice that they really don't feel good. Okay, they might just be like, I'm just a little tired, but they're actually really, really ill. So a lot of times identifying illnesses gets delayed because they don't notice those signs and symptoms. Other things that really can impact how willing an elderly patient is to receive care is what their social and emotional factors are. Um, right? Are they reliant on someone else for their care? Are they alone? Are they concerned that if they go to the hospital, they'll never make it back home? Are they worried about their cat slash dog? Okay, like, hey, my pet needs to be taken care of. I can't go to the hospital, right? A lot of people, as they get older, start to lose family members. They start to lose friends. So, you know, they see that and they know that that's going to be their future also. Like they're worried about those things. They don't want to lose any of their autonomy and their independence. The hospital isn't, a place like when you're younger. The hospital means like, oh, someone's having a baby. As you get older, like it's no, someone's going in and dying, or someone's going to be on a like event, or someone's going to have a long-term stay and they get discharged to a nursing home. So you want to make sure that those are like maybe some fears that you can kind of alleviate for a patient. And also financial concerns, right? A lot of elderly patients are on a fixed income, and aren't confident that they'll be able to pay for that level of care or the care that's required for a nursing home and stuff like that. Because patients tend to have, or elderly patients tend to have more comorbidities and other issues, it might take you a longer time to get their history, right? It might be a little bit more complex. You might have things like, hearing or visual concerns, okay? You might not be able to communicate with them because maybe they're feeling stubborn or they're feeling, obstinate that day. They don't really want to. But you have to be very patient with these patients to use that a lot. Right. So just make sure that when you are, acquiring this, you introduce yourself like you would do with almost any other patient, right? You're going to introduce yourself. You're going to make sure that you're being respectful, that you're being professional, and that you're putting yourself in a place where they can see you, they can like look at your face, potentially read lips if they need to, and you want to make sure that you're preserving that patient's dignity. Um, there's a surprising number of older patients who are alcoholics, so don't forget to look for those things. Abuse of medication or non-compliance with medication. Okay, sometimes a condition of the home can, or an assessment of the home condition can also provide a lot of information about the patient, as well as, something that you can report to the hospital, like, hey, like this is the patients that home is not safe, like they can't go back, they need social services, they need something, they need assistance, like they are unable to walk up the stairs to get to the bathroom. All right, there's a whole slew of different issues that could arise, you know, and you're the only medical professional who's going to be invited into that patient's home. So you want to make sure that you're getting a good idea of what's going on. For example, I had a patient once. We walked into the front of the house. The front of the house looked clean, very neat. I passed that first room and it was a disaster. Okay. The fridge wasn't plugged in. The fridge was full of pudding cups. Like that was it. That was the only, and like when I say full, I mean like it was one of those double open doors, top to bottom, front to back, completely stocked with pudding cups and nothing else. Um, there were stacks and stacks of mail. Yeah, there's a certain amount of time where you're like, that's enough pudding. There was mail stacked everywhere, bills unpaid. The bathroom was like just there was just black like up the wall. Like it wasn't a safe situation. But if you walk in that very first, that first foyer, you're like, oh, this is very well kept. Yeah, there's always a little bit more to the story. So don't be afraid to like maybe do a little wander and find out, get a good picture. Um, this is kind of one of those things that goes across the board. Respect the patient's modesty and dignity. Explain what you're doing before you do it for the patient. Um, if your patient is like a little like, oh, I don't know, it's not too bad, you should probably take it a little more seriously, even though they're trying to brush it off. And if you have a patient who, you're trying to determine if it's a new issue or a chronic issue, okay? How long has it been going on? Is this new? Does it feel like your previous issues? Has there been any like change in patient's mental status? Sometimes you're going to need to, rely on some family members to give you a little bit of history also. All of a sudden, are they no longer able to walk? Okay. One thing I will say, if you're doing a neuro assessment and you ask the patient to hold their arms out, okay, and one of them they're unable to pick up, please check. Please do a quick like palpation of that arm. I've seen at least 2 or 3 times when a patient was called as a stroke note and they had a fractured humerus, and that was why they couldn't lift their arm. Okay, so don't forget that just because oh, I fell from standing or I rolled out of bed doesn't mean that that fragile body has not sustained some level of trauma. Okay, always have that as like a suspicion in the back of your head. Things that you might or you will definitely encounter when dealing with the elderly, bacterial pneumonia. Okay, um, things like aspiration, right? Anything that's inside the lungs that doesn't belong there, and by doesn't belong there, I mean is not air, can cause pneumonia. Okay, it likes warm, dark, moist places. Your lungs are those things. Okay, when that cilia goes away, like that mucus movement isn't as great, you might not be like loss of chest wall strength isn't makes maybe that coughing isn't as strong enough to clear the airway. They might not be able to take a good solid deep breath. Um, COPD, right? Very common, very widespread issue. Um, Not only is it make can it make daily activities of daily living, or ADLs, challenging, but it also makes it really hard for a patient to breathe, right? Even if they're not necessarily exacerbating their COPD where there's an emergency treatment, they're still potentially having a hard time breathing. They might be on chronic O2 therapy, right? You might have that 80 feet of nasal cannula flowing throughout the house, all right? So those are things just to take in consideration. Um, as patients get older, chest pain becomes a less common symptom. And things I would like to remind you, chest pain, crushing chest pain in the MI is was studied as the quote unquote hallmark symptom of myocardial infarction on men alone, right? Women weren't part of that study. So the number one symptom for women who are having an MI is inexplicable fatigue. 80% of women having a heart attack will describe their symptoms or their initial symptoms as inexplicable fatigue. Okay, maybe some nausea, maybe some vomiting. And this kind of goes the same way for, the elderly. Okay, as they get older, it's going to be fatigue, it's going to be discomfort. It's not going to be that necessarily that crushing chest pain that we so commonly associate with an MI. Other issues, if patients had a previous MI, you should have a very high index suspicion that they're having another one. High cholesterol, high blood pressure, especially those two if they are not maintained medication wise properly. Diabetes, especially, right? Diabetes can present as almost any symptom, any vague symptom. It could be an MI. So always have a high index of suspicion for your diabetic patients, especially your elderly diabetics. Heart failure. There's a huge movement in EMS, in paramedicine in particular, of trying to maintain hospitalization or patients at home with before they end up needing to be hospitalized for heart failure. Okay, huge push. Trying to make sure that patients are taking their medications properly, that we're catching exacerbations of those heart failure issues before they become so severe that they need to be hospitalized. One of the things that you're going to see, especially now we're moving into the holiday season, any amount of salt change or stress change can trigger a heart failure episode. All right, so now we're moving into holidays. Everyone's got their, we're having the turkey, we're having the mashed potatoes, we're having all this food that we don't usually have that might be very high in sodium, and that can trick or trip up a heart failure patient who's very, very carefully balanced with their fluid. Okay. Stress also. I don't know about anybody else, but families are stressful. You go to holidays and all of a sudden, Auntie Carol is having an argument with Bob, and grandma's trying to get in between to make sure that no one, that we can have a nice holiday, and it's just too much, right? So you'll see a lot of cardiac and respiratory problems. There's actually a syndrome called Christmas heart where patients, they will see, or holiday heart, you will find the number of cardiac related events and pulmonary related events spike dramatically during November, December, and a little bit in January, right around the new year. Uh, Hypertensive hearts usually end up creating dysrhythmias. AFib is the most common dysrhythmia. The source of AFib, the source packet of cells that creates that fibrillatory rhythm, is usually around the aortic valve. So patients who have aortic valve disease tend to also end up having AFib. PVCs are super common, but they're kind of super common across the board. But always, if you have a patient who has a dysrhythmia, always keep in the back of your mind that it might be an electrolyte imbalance. As you get older, abdominal and thoracic aneurysms become more common, very common in men. Okay. Um, Most of the time, acute dissecting just aortic aneurysms are a little more common than abdominal. Okay, so you that up high in that thoracic region, that's much more common than like in the abdominal region. Um, you may or may not see these. You may pick up on them. Always, doing a blood pressure on both arms is always good practice to see if you have that difference that might clue you in that there's an aneurysm occurring. They keep changing what the resting blood pressure threshold for hypertension is. A couple years ago, it was 140 over 90. Well, now we are all the way down to 130 over 80. If you have a blood pressure of over 130 over 80 at rest, you are considered hypertensive. A lot of different things can cause hypertension, atherosclerosis, of being older, diabetes, obesity, um, failure of, like you're not moving or exercising enough. Uh, Once you get to a 180 over 120, it's usually considered hypertensive crisis. Um, there are patients who live there all the time. At that point, the crisis would be considered elevated blood pressure plus visual disturbances, headaches, nausea, vomiting, anything like that. So you would have other symptoms associated as well. Uh, Chronic high blood pressure can cause all sorts of issues, kidney failure, heart failure, heart attack and stroke, but peripheral vascular disease, aneurysm, blindness, right? You have a lot of little blood vessels in your eyeballs that, don't necessarily want to get beat with extremely high pressures. Cerebral vascular disease and or stroke. Well, if you have a stroke, you are much more at risk to have another stroke. Always remember, TIAs are a stroke until proven otherwise because, you know, it might not be going away. Stroke also, TIAs are a warning sign for a bigger event. So these patients will, once they start having TIAs, they need to be like kept, a closer eye on overall. High blood pressure, diabetes, all of these issues, right? Anything that's going to cause increased pressure in the vasculature or unnecessary constriction, right? Heavy smoking causes a lot of constriction in your vasculature, so narrowing those blood vessels is an issue. Um, Overall, stroke is one of the most debilitating diseases or events that a person can experience, right? Think about it. Like if you have a stroke, like all of a sudden you can't move half your body if you don't catch it in time, right? So now you're reliant on um, you know, durable medical equipment, assistive devices, maybe a family member to get in and out of bed, right? It can cause a lot of issues. You can't communicate properly. So, um, delirium, not to be confused with dementia. Dementia is a long-term issue. Delirium is very acute. Okay, so an all of a sudden onset of confusion, altered mental status. Most of the time, delirium is considered reversible. They have to find the root cause. Sneeze and my nose would stop. So that the potentially reversible thing could be an electrolyte imbalance. It could be that the patient's has a history of dementia and maybe they're sundowning or they're experiencing some other acute issue, liver problems, right, where they might have high levels of ammonia. Alcohol abuse is always, an issue or a possibility. Um, Delirium tremens from alcohol or not drinking alcohol. Any other medical problems, medications as a whole. Um, Certain steroids can cause delirium. It's pretty wild. So there's a number of different medications that have a side effect of delirium that they try to avoid giving to patients, especially patients who might have an underlying dementia history. Here you go. Here's some I watch death. We love our mnemonics here in EMS. Infection, withdrawal from medications or alcohol, acute metabolic condition, trauma, CNS issues, hypoxia, deficiencies like in electrolytes, endocrine problems, acute vascular problems, toxins and drugs, and heavy metals. Okay, these are all possibilities of what might cause delirium. So, dementia is a progressive loss of intellectual functions. It might start off slow It might hit hard. You'll have patients who might have a little bit of dementia, and all of a sudden they'll have this huge jump of confusion, and it doesn't go back to being better. Okay, and like you'll get the phone call that they think the patient's delirious, but it's actually their dementia has taken us a huge step forward. Always a possibility. Um, Most of the time, they have a hard time with learning new things or recalling recent events, as opposed to Alzheimer's, which they will just overall like global issues. Um, Neither of these are actually a normal consequence of aging. There's a bunch of research on both of these disease processes that they're trying to get to the root of, but it's not normal to have dementia. Maybe a little forgetful here and there, but full blown loss of memory function is not normal. And especially, I don't know if anyone knows anybody who's on the older side, but is still sharp as a tack. Okay, so clearly, when you have that precedent of people who, make it to the end of their life really sharp, having these like, cognitive issues is not a course of aging. Vascular dementia is usually secondary to a CVA. Okay, so there's or a reduction in blood flow. Like so, they're basically the brain is just desperate for oxygen, so it's damaged, and that's why it's not like an overall process um, where the brain is starting to just decrease. Excuse me. Um, then you have Parkinson's dementia, right? So a patient who starts having who has Parkinson's, average from when they start to lose their cognitive function is about 10 years from the onset of Parkinson's. Um, Lewy body dementia, right? So there's these little things that can be popped up as called Lewy bodies in the brain, causes hallucinations, also fluctuating mental state. Frontotemporal lobe dementia, they have a hard time with making decisions in time, like understanding like their movement through time. Diabetes. Type 1 diabetes is a lot less common than you would think it is. Type 2 diabetes is taking a quick push to the front of being most common. Um, of the patients who are 60 and over, about 90% of them have diabetes. Okay. Again, type 1 diabetes is often considered an autoimmune issue. Type 2 diabetes is an insulin um, resistance. Okay. But either way, they tend to have a lot of the same issues, um, right? That causes a lot of the same damage to the body because sugar is a huge molecule. And as sugar goes bouncing around your bloodstream, it just damages everything in its path. Okay. Diabetics strive to keep their sugar in a very narrow kind of therapeutic range. All right. They have therapy dogs for, making sure that their sugar is in a good spot. Unfortunately, as patients get older, that those classic signs of hyperglycemia, right, the little flush red skin, like hyper, the tachypnea, um, very hot, they might not show up. So most of the time, it could just be that there's confusion, the patient has fallen, urinary incontinence, right, or the thoughts of a UTI. Usually, infectious processes will screw up diabetic patients' sugars. Okay, it just throws it all off, and they might be hyperglycemic without knowing it. It's good practice to get a blood sugar on diabetics, even if they're type 2. Hypothyroid, the number one prescribed medication in the United States is Synthroid. Okay, the thyroid is just like quitting on us here in this country. It can cause a lot of different issues. A lot of patients will know when they're younger that they have hypothyroidism, but as you get older, it also pops up a lot. Um, right? Thyroid helps with a lot of your metabolic things. So feeling awake, feeling hungry, gaining weight, losing weight. The thyroid is all, contributes to that. So you could have a lot of patients who are experiencing confusion or fatigue, um, cold intolerance, um, can also affect the heart if the thyroid levels are too low. Okay, so you have dysrhythmias, heart failure, seizures, coma. Once you get to that coma stage, it's usually considered mixed edema, which means it's extra low. The patient will be very cold to the touch, have very like doughy skin, like very squishy. Here you go. Mixed edema coma. I have seen this a grand total of once. Uh, and it's actually pretty wild. So the patient will be altered mental status, either it's undiagnosed and untreated, or just patients not taking their medications, poorly managed, but they will get what's that top left picture is that quote unquote doughy appearance. Okay, they'll be very cold. Their extremities will be very doughy and pudgy looking. And once they start to manage that thyroid, they will be, and get their that thyroid hormone to the right level, they'll look like 100% better. Hair loss is very common in hypothyroidism. Um, Hypoxia because they're not breathing because of the depressed respiratory rate because their metabolic needs are just tank. GI bleeding. You will 110% encounter this across the board. Uh, Diverticulitis becomes much more common as patients get older, okay, and it can lead to GI hemorrhaging. It could be cancer, it could be esophageal varices, peptic ulcers, ulcers anywhere along the intestinal tract. Um, GI hemorrhages tend to have a very high mortality rate as patients get older. The very first time that a patient has a GI hemorrhage or GI bleed tends to be the worst. Okay, because most of the time they don't necessarily recognize the signs or symptoms and have significant bleeding before it's caught. Bowel obstructions, all right, as you get older, that peristalsis motion starts to slow down. So it's a little harder for you to have a bowel movement. Patients who maybe have a hernia or surgery, colon cancer, okay. Um, if the patient has said that they haven't had a bowel movement in a number of days and they're unable to pass gas, that's really not a good sign. Vomiting fecal matter is also not a good look. I had a patient once, he hadn't had a bowel movement in 12 days and he had started vomiting fecal matter, and the family wanted to go to Northwell, shock and surprise. And I was like, yeah, we're going to the closest hospital because he's got airway compromise now and he's a surgical emergency. So he didn't go to Northwell that day. Incontinence also has an issue. Motivation is a huge issue when it comes to incontinence, right? As a lot of geriatric patients get older, they get a little depressed. So maybe they don't really want to get up, or maybe it's hard for them to get up. Maybe they have mobility issues, where they have a hard time getting to the bathroom. It's a lot of work. Maybe they're on Lasix, right? Maybe they're peeing every 20 minutes and they're just tired of it. So there's a lot of different things that can kind of play into this. Sphincter um, contraction starts to loosen up a little bit as well as you get older. So the problem with it is not only does it increase your risk for UTI, it increases the risk of skin and tissue breakdown, right? Those quote unquote bed sores, okay? Because being in a wet environment is not good for skin. Skin needs to be dry. Sometimes there's another side of it where elimination issues, right, where they can't urinate. This is commonly seen in patients who either have like renal failure or maybe BPH, prostate problems, UTI, where they feel like they have to go, but there's nothing going on. Um, Colorectal cancer also can cause tumors that reduce the ability of the body to have bowel movements. As you get older, your skin starts to dry out. We talked about this already a little bit, right? Because your subcutaneous fat, it gets thinner, which also now leads to not great thermal regulation. So you're colder more often, increased risk of infections, or very like commonly seen like skin tears. Um, you just start breaking down, dust to dust. Good. Pressure ulcers. Um, Basically, pressure ulcers result in a bony structure pushing against um, a harder surface or hard-ish surface, could still be a bed, and resulting in tissue hypoxia. And as that tissue gets less and less oxygen, it starts to break down. You see this a lot in patients who are bedridden or immobile, who aren't maybe necessarily getting appropriate care. Lower legs, backs, buttocks, sacrum, very common areas for pressure ulcers. Obviously, we do not like necessarily grade pressure ulcers, but you can tell there's a number. It goes from being one where it's just like this red spot that doesn't seem to get better, to becoming like an ulcer, to a full thickness ulcer, to extensive destruction, tissue necrosis. In case you forgot what it means to get older, osteoarthritis is a joy. Most of the time, osteoarthritis develops in joints that are being used repetitively. So you'll see patients who they played baseball or baseball pitcher as an throughout their life. They have osteoarthritis in their elbow and their shoulder. Um, there's a destruction of that cartilage, and it just leads to bone on bone, and it causes joint stiffness and pain. Osteoporosis, the bone starts to thin out. This is very common in women after menopause because of that loss of estrogen. Once you hit 70, it's kind of it's equal. This is why we worry about patients who have taken a fall from height, even from standing, because this thin, porous, brittle bone can break very easily. You'll see a lot of patients, the femur head, that hip vertebrae, right? The compression fractures. If they fall flat on their butt, they'll end up with a compression fracture because the bone is not dense and it just goes smush. Vision, as we talked about this already, right? A lot of times your vision will change as you get older. You could have less ability to see. Reading and driving become issue. Depth perception overall. Cataracts can develop. Um, Cataract is a loss of transparency of the lens over the eye. They'll do that's very commonly you'll see, like, so they have that cloudy look over their eye. Um, you might see patients who have damage to their pupil, and they have their pupil isn't round, it's like got a nick in it. Usually that's secondary to some sort of eye surgery. If they're older, it's usually cataract surgery. They'll take that cloudy lens off so that the patient can see better. Glaucoma is the second leading cause of blindness. It's an increase of intraocular pressure. Again, you might have a patient who has glaucoma. They might be complaining of like aching pain in their eye. Uh, for the most part, you want to make sure that there's a few medications here and there that we give that you shouldn't mix with patients with glaucoma. But again, if it's life over limb, you're going to have to use your judgment call there. Hearing, right? Hearing also starts to get worse as you get older. Um, could be due to drugs, could be due to the degeneration of the hearing mechanisms, Meniere's disease, which is increased fluid in the labyrinth. Tinnitus, Lasix. If you push Lasix too fast, you will give your patient tinnitus forever, and they will hate you forever. Okay, so make sure you push Lasix very slow. So this could interfere with your ability to get patient history, right? Any medical history or history of the chief complaint. Speech, sometimes it's a little harder for people to find the right words. Sometimes they're maybe very quiet, okay, right? As the chest wall starts to get less strong, it's harder for them to really support their voice, so they might have a very low, quiet voice. They might have choking issues or like clearing their airway issues that would interfere with being able to speak loudly. Other damage to language centers of the brain, right? Maybe a stroke, maybe dementia, Parkinson's. Any of those things can impair speech. As you get older, toxicology becomes a bigger concern, right? So again, we talked about this already a little bit, but when you start mixing and matching medications, um, are at increased risk for having an adverse reaction. On top of that, body composition changes, right? That increase in body fat will affect drug absorption, metabolism, excretion. How well your kidneys are functioning and your liver is functioning is going to impact your excretion. Um, as you get older, you have increased gastric pH and a decreased motility, so that drug is sitting in that acid longer. A decreased cardiac output means that the drug's not going to be distributed to the body as well. Same thing with loss of total body water, right? There's less plasma for it to float around in and get to where it needs to be. That change in the ratio between lean mass, um, like your muscles, and your fat, that increase in body fat, that body fat's going to hold on to the medication. It's not going to necessarily get to the tissue that it needs to, but at the same time, it's going to extend the life of the medication. Decreased liver blood flow, right? So that first pass metabolism of a medication might not occur as effectively or as quickly. Thyroid disease interferes with a lot of medications, right? Because if you're not digesting it properly, you're not going to have that medication uh, in the form it needs to be. And we talked about kidney. Most of the time, these are the medications that you're going to see having issues in terms of drug toxicity. A lot of the times, it's accidental, secondary to a dispensing error, okay, or confusion. One of the only times I got to treat a beta blocker overdose in the city was an older woman had a very gentle touch of dementia, and she had taken 2 or 3 doses of her medications out of her pill box that day because she had forgotten that she had already taken them. So she ended up with, her blood pressure was crap, her heart rate was 40, and she was like cool, pale, diaphoretic. So, we put together like, oh, hey, she's missing a number of days in her pill box. This is probably what happened. And they gave us the calcium, they gave us the glucagon, they gave us dopamine to treat her and get her back to where she needed to be. Um, so any of these medications can cause toxicity, um, have different presentations depending on substance abuse, right? No one can 100% avoid substance abuse. Any age, gender, any race can deal with substance abuse issues. Most of the time, it's due to stress, financial, social stresses, right? Can cause a lot of issue. Um, Becoming increasingly depressed and lonely. Um, Becoming knowledgeable of the fact that the end is nigh or whatever, right? That there might be a significant change in their life. Maybe they've retired, maybe they've lost a partner. So a lot of different things. Always have a gentle suspicion for substance abuse. Hypothermia can occur even while the patient's indoors, and even if it's a technically room temperature, right? Because when you're chilly, you get up and you get a sweater or you change the heat. Um, Sometimes you won't, elderly won't notice that they are cold right away because maybe they are lost that train of thought. Maybe they're unable to go get a sweater. Maybe they're just, they can't afford heat. Maybe they'll just kind of figure it out. Um, so a lot of times their compensatory mechanisms start to fail. So you always, be attentive for hypothermia. Um, Other issues is that there are medical causes of hypothermia, right? Um, Sepsis is pretty high on my list for hypothermia issues, but patients who have mobility issues like Parkinson's or stroke, um, they can experience serious hypothermic issues because they are unable to potentially take care of their needs. Thyroid disease, right? We talked about myxedema. Those patients will be very cold. So malnutrition, if they don't have, appropriate storage to create heat, they're not going to do it. Hyperthermia is a lot less common because patients tend to be chilly all the time, but it does tend to create a higher mortality rate. You'll see this unfortunately during like the summer, where there's a heat wave, and all of a sudden you have a number of elderly who are dying because they're being exposed to this ridiculous high temperature, and they don't necessarily notice it, or they don't think that they're cold. They don't sweat. As you get older, your sweat glands start to deteriorate, so you don't sweat as much, so you can't regulate your temperature well. It just becomes kind of an entire conglomeration of different things that can make environmental things very dangerous for the elderly. We talked about depression already. Again, right? A lot of things. It could be dementia. It could be behavioral disorders that are kind of popping up to the front of being poorly managed. Um, do always have a bit of a suspicion of accidental medication overdoses as being a suicide attempt. It's pretty easy access. You give somebody like 60 metoprolol pills, they can take themselves out pretty easily if they are severely depressed. Um, Unfortunately, a lot of the signs and symptoms of depression are kind of overlooked in the elderly population because it's just like quote unquote expected, right? It's just a normal age change. Oh, you've lost your appetite. Yeah, you've lost weight, or you're not sleeping well. Oh, that's a normal change associated with age. The other things, the worthlessness, guilt, right? Survivor's guilt is a big thing in the elderly population where why did my partner die and I didn't? I'm all alone, that isolation, right? Especially people who don't live anywhere near their family. they can have a lot of problems with that as well. Suicide rates of the elderly or adults over 65 tend to be pretty high. Completion rates are also relatively high because they usually have the means to do it. Um, Either they just stop taking their medications, or they'll take too much of their medications, they'll take unnecessary risks, prize possessions, get their affairs in order. Um, you have to kind of be a little careful though, because talking about death or being preoccupied with death might be just they know the end is near. Maybe they're really sick. Um, we tend to under triage elderly patients in trauma. I think EMS probably does a better job of over triaging than the hospital does, because we're like, I'm suspicious. I'm suspicious of this. The patient's taking Coumadin, and I don't care that they just fell from height. Like, I'm calling this in as a trauma note. And you get to the hospital, and they're like, maybe, maybe not. So the combination of blood thinners and beta blockers is extremely deadly in elderly trauma patients, because you have a patient who is bleeding out with no compensatory shock mechanism, right? They can't elevate their heart rate to increase their cardiac output. So they're just kind of quietly, bleeding out, and there's no signs and symptoms that we can notice. Things like ARDS, okay, acute respiratory distress syndrome, is increased as patients get older, because they already have a decreased respiratory function. So you're not working with really healthy lungs as it is. Um, Again, you have osteoporosis, muscle weakness. A lot of these things, if you fall, get hurt as a young person, you have, good muscle tone that might, dampen some of the damage. As you get older, you have very thin, brittle bones, lost less muscle. It's going to be more damaging than otherwise. Most of the time, falls can be prevented. This is one of those things when you start walking into houses. Uh, if you see things, fall assessments, this is a huge community paramedicine movement also, is that, hey, like, we need to put a handrail here. Hey, let's put a handrail by the bathtub or by the toilet. Or, hey, do you really need this throw rug? Because it's a trip hazard. Um, Once they fall that first time, they starts to set in that fear, right? Patients start to become really nervous about, do I really need to go outside? So they start to create this self-imposed immobilization. And then immobilization is not only like, well, I'm not going to walk around or anything. Um, it's more like, I'm just going to, I'm going to hang out right here. I don't need to go out to the store, right? I'm just going to do the minimum. Hip fracture tends to be not only the most common, but has the highest 1-year mortality rate, at about 20 to 30%. It's higher in some places also. Um, so we talk about that. Vehicular trauma, okay. 70 to 74 age group, fatal crashes, very high. Decreased response times, right? Increased risk of injury. Um, Pedestrian versus vehicle, right? Getting hit by a car. Maybe you didn't cross the crosswalk as fast as you could because you have mobility issues. A lot of different things that, car accidents can cause. We'll talk about that more when we get to trauma. Same thing with burns. We're going to talk about burns more in depth when we get to the trauma section, but um, you lose a lot of plasma due to burns, right? Your depth, that loss of subcutaneous fat, is going to mean that burn depth is going to inherently be higher. Um, Impaired nutrition brought to you by, loss of appetite or inability to chew well, is going to decrease your ability to heal. You're going to have less total body weight, which means you're going to have less plasma in getting. And so when you lose a lot of plasma due to burns, you're going to be even worse. And then you have to worry about fluid overloading patients. So the number one thing that we do to treat burns is we administer lots of fluids via the Parkland formula. But if you have a patient who is an elderly patient who's, got renal impairment, might cause fluid overload, and now that you have to put them on CPAP or you have to ventilate them because their lungs filled up with fluid. We talked about head trauma already, okay? The elderly tend to fall, and when they hit their head, the signs and symptoms of a head injury take a little bit longer to be noticeable because they have more space between the brain and the skull. You lose that elasticity of your veins, which means it's more easily torn. So just a lot of things you want to keep in mind. Same things with chest injuries, right? If you damage the chest, that lack of elasticity causes a higher increase of respiratory compromise. Functional reserve patients aren't going to be able to breathe well. Um, and you also have a thinner chest wall, so you could do more damage to potentially the heart and lungs. So not only a myocardial contusion, but a pulmonary contusion. So you're going to really decrease not only the cardiac output, but the ability to breathe effectively. Always have a high risk of suspicion for abdominal injuries. Bones, we talked about this already. Don't forget, we talked about a lot of these things already. Be cautious when you're dealing with trauma patients who are older. Um, if they've had a previous heart attack, there's increased possibility of seeing dysrhythmias or heart failure. They might not be able to compensate as well um, in response to any of, a traumatic event or a hypovolemic situation. Um, just because a patient has, you know, an, a blood pressure of 100/70 doesn't necessarily mean that that's not a shock state for them, right? If they're living at a level of high blood pressure or hypertension, right, and their normal blood pressure is like 170/90, 110 is or 100 could be potentially really damaging to them. Their body's expecting a certain level of pressure of blood. And again, IV fluid, always be cautious because of the potential fluid overload. When you're ventilating trauma patients, you always have to make sure that you are very cautious. You can cause barotrauma by over enthusiastically ventilating, right? Especially if the patient has comorbidities like COPD. Um, organs don't tolerate hypoxia very well. Same thing, fluid overload, the kidneys participate in this as well. Um, you also might see a patient who's going into an acidosis state a lot faster than you would anticipate because again, they're not able to maintain that normal range as easily as everything starts to get older. Um, Again, a lot of the time our transport is relatively short in this region. So you want to make sure that you're positioning and immobilizing your patient appropriately, make them comfortable, keep them warm. It might be 90 degrees out and grandma might be still chilly. That's okay. Get her another blanket. Like, just bundle her up if she says she's cold. Like, there's no reason for you not to do those things. Turn the air conditioning off in the ambulance for a little bit. Okay. There's no reason that you need to do damage to somebody just because you're uncomfortable. Be uncomfortable for a phone. Elder abuse, always a big issue. And a lot of the times, this is not necessarily easy to notice. And a lot of the time, it's a caregiver who's the perpetrator of elder abuse, and that person is a adult son or daughter um, who that elderly individual is relying upon for some level of care. The problem is that they are so reliant on care that they don't necessarily want to report their loved one, their child, right, for the problems that they're being caused. And this could be any number of things. Most commonly, you'll see financial and material exploitation, okay, where, well, we're using your social security check to pay our mortgage, or we're doing something, and like there's a lot of um, guilt and uh, anger around the whole thing. So always make sure that that's fair. Same kind of thing as you would see in child abuse. You want to make sure that there's different injuries or there's a delay in care being provided, or the patient looks fearful, that you kind of take that into consideration. Always be suspicious. Be suspicious of everybody. EMS will do an amazing job of absolutely positively destroying your ability to trust other humans. Wild. All right. Thoughts, concerns? Maybe yes, maybe no. Good, not good. All right, cool. So next up for today, we've got patients with special challenges. Then we're good. It's like we talked about a lot of these things already. So not only the elderly, but everyone in general can have various challenges that make it an interesting event to be an EMS provider. Hearing, visual, or speech. Um, Deafness, right, is profound hearing loss. While total deafness, where you can't hear absolutely anything, is very rare, it is considered congenital. Um, a lot of the times, uh, they'll start babies very young with the cochlear implants or hearing aids so that there's no speech delay. Most of the language that we learn, like, is from a very, very young age, even in the womb. Like, as a fetus, you're already learning language through the reverberation of mom's voice, which is kind of creepy about it. Um, then you have conductive hearing loss, which is the failure of sound to make it from the outer ear to the inner ear. This can be curable. This might be like a really bad um, ear infection, right? Something that's preventing the hearing, the sound from getting into the ear. And then you have sensorial neural hearing loss, which is the sound is getting to the ear, but it's not getting to the brain. And this is often considered incurable. Mixed hearing loss, central hearing loss, right? There's a mixed hearing loss is like a combination of different things. Central hearing loss is there's some sort of damage to the brain itself and not the ear or the nerve from the ear to the brain. It's the brain portion. And then auditory neuropathy is like it's out of proportion with the hearing loss. So the ear might detect the sound, but it can't get it to the brain. It also is usually associated with some level of speech difficulty. Some hearing assisted devices that you might see. This is your standard run of the mill hearing aid on the left. Okay, so the hearing aid has a battery. It has a mini receiver, an earplug that goes in, and a volume control, right? So this is basically the patient's having a hard time getting the sound from the outer ear to the inner ear, and we're going to make it as loud as possible, okay? If you have a patient who has a hearing aid, if you put your hand close to the hearing aid, it usually will make a noise, and that's how you know that the battery is in good shape. On the right, you have a cochlear implant. I am not 100% sure how cochlear implants work, but it does take the sound and it transmits, I believe, it right into the brain. Um, a lot of patients who have hearing issues will be able to do some level of speech interpretation through like lip reading or something like that. It is not 100% lip reading, is actually only about 20% of actually looking at what the mouth is saying, and the rest of it is context clues and facial expressions. So you want to make sure that you're not being really dramatic when you're trying to get someone to read your lips, because you're going to give them the wrong context, right? So speak at a normal pace, because too fast or too slow is going to make it harder for them to pick it up. Sign language is always good if you know some sign language, but if you're having a hard time communicating with a person with a hearing impairment, you can always write it down, right? Or you can put it on your phone, text it out for them, and have a conversation via writing. It's a lot easier than doing like charades if this, lip reading isn't working. When it comes to visual impairments, right, again, just like hearing impairments, it could be any variety of combinations of how their vision is being impaired. You can be considered totally legally blind and still have the ability to see shadows. Okay, like a lot of blind people or people who are considered blind get a lot of nonsense from people who are like, but you're walking without your stick or without a dog or any number of things. These things, it's like, yeah, I might be, but I can still see shapes. I can see, I can't see colors, but I can kind of see out the peripheral vision. It's not good enough in comparison to like perfect, perfect vision where you're like, exactly what's going on. So it could be secondary to cataracts, really bad cataracts, damage to the eyes, optic nerves, brain injuries, infections, long-term visual impairments of that come like affect children is usually due to infection that is picked up during birth, right? The cytomegalovirus or the herpes virus, like picked up during um, the birthing process through the vagina, vitamin A deficiency. I'll send you that later. Speech impairments, right? There's a possibility for language issues, right? It could be articulation, voice production, fluency. Um, a lot of the time, speech impairments are caused by head injury, brain tumor. One of the other things, though, is you have people who have just a speech impediment. Okay, um, is maybe a stutter. Most of the time, be patient. Okay, patient. Those people don't want you to fill in their sentence. They want to be able to get it out, because if they aren't able to get it out, it makes the stutter worse. So you have to take a back seat and try to be patient. Don't push them, because you're just going to make it worse. Oh, aphasia is a complete loss of power of speech, and with a difficulty understanding speech from other people. Okay, and there's different combinations of aphasia. Um, okay, that I think we talked about in another. So you might see that there's language development issues or delayed speech problems due to hearing loss, right? A lot of the people who have hearing impairments, you tend to hear that they have a speech, a very unique kind of speech, like they're kind of muffled, because they're hearing it muffled. So maybe their voice is going to also have that same kind of issue. A lack of stimulation, right? If we aren't stimulating children from a very young age, they're going to have problems with speech, emotional disturbances, brain issues overall, any sort of damage to the nerve. Um, Dysarthria, motor speech disorder, right? This inability to produce speech sounds. So there's some sort of issue where the muscles of that produce, your voice aren't working properly. Hoarseness, harshness, inappropriate pitch, nasal resonance, all of these things, a lot of kids go to speech therapy for. Um, it could be that there's a vocal cord problem. Fluency disorders is you see that stutter, right? Repetition of single sounds, or blocking something that blocks their speech to be continued. Just things to take in consideration while you're dealing with patients. Obesity. Obesity is officially defined as being 30% above ideal body weight, which, depending on that definition, could be wrong. I don't know if you are 30% over your ideal body weight because you bench press Volkswagens. I'm not going to call you obese. That's just not going to happen, because you're probably going to fight me. All right. It's a, what is the body composition that's being seen also. You have to take those things into consideration. Um, some diseases associated with diabetes or with obesity are diabetes, heart disease, stroke, cancer, osteoarthritis. Your run of the mill, chronic, no good, no, not a happy day diseases. A lot of times, obesity can be caused by either genetic disposition, a low basal metabolic rate. Chromosomal issues can cause a lot of obesity, right? Like kids who were born with Down syndrome tend to be on the heavier side, okay? Just inherent with the syndrome. Any sort of caloric intake that exceeds the calories expended, right? Calories in, calories out. Um, but when we talk about this, you also have to worry about, obviously, the other side. You have eating disorders, which are just as damaging. We have specialty equipment to help move obese patients, right? The nice thing about power load, power stretchers now is that we don't have to do a lot of that heavy lifting anymore. There are ambulances that are bariatric specialty equipped, where they have this ramp that it will lift the whole thing. This was pre-power load. Um, and again, you need to know what the weight rating is. If you have an extremely obese patient and you're bringing them to the hospital, you should probably get the hospital notified quickly, because they're going to need a specialty bed as well. Some extremely heavy patients aren't going to fit on your standard hospital bed. For this, they took this woman out of her window. She weighed over 1,000 pounds. For a good day, we have to crane you out of your apartment. Bariatric surgery, you'll see this every once in a while, right? This is extremely common now. Number of different things that can, bariatric surgery is done is, one is the bypass, where they completely cut the stomach out and just put you right into the intestines. You can have a sleeve gastrectomy, right, where they either put a constricting sleeve around the stomach, or they just turn it into a much smaller device. Gastric band, which is adjustable. They put essentially like a hair tie around your stomach to make it very, very small so that you feel full faster and reduce the number of calories. I'm not even going to try to say that word, right? So a lot of different varieties they use to help people lose weight. The problem with bariatric surgery is it's surgery, right? Any surgery comes with inherent risks. It could be clotting issues, respiratory issues, bleeding, infection and sepsis, um, vomiting, dehydration, right? Patients who, okay, I just had this surgery, I'm going to eat, it's like my stomach can now hold about a grape. I'm going to still go out and eat that double Big Mac. They're going to have issues. They're going to, pop a stitch. They're going to, cause an organ rupture, all sorts of other problems. Electrolyte disturbances are also a possibility, reflux, etc. All right, paraplegia, right, is considered weakness and paralysis of both legs, sometimes part of the trunk. Quadriplegia is weakness and or paralysis of all four extremities. Some patients who are quadriplegic will have a level of movement in their arms and hands, more or less enough to maybe use a motorized wheelchair. Do not assume that someone is a paraplegic just because they can move their arm. They might require more assistance and care than that. A lot of the times, brain and spinal cord damage, right? Traumatic injuries, lupus, multiple sclerosis, stroke, Guillain-Barré, since that's apparently one of our new, we like to talk about that. That's a potentially temporary paralysis, ascending paralysis, starting from the feet going up. Okay, so paralysis can be caused by any of these. Um, a lot of times when you have that superior inferior paralysis, there's a loss of bowel and bladder control. So those patients either will have to use a straight cath to relieve themselves, um, or might have skin issues. Anything when it starts to get higher, the higher level spinal injuries, right? C3, 4, 5 keep you alive, right? That's where your breathing centers are usually located. The diaphragm, the phrenic nerve is. If you have a very high level spinal injury, the patient's going to potentially have difficulty breathing. One of the most common like more or less emergent issues that you might see for paralysis is called autonomic dysreflexia. Okay, usually it's a spinal cord injury of T6 or higher, and there's some sort of irritant below the site of the injury. Oh, no, I don't have it. There's an irritant below the site of the injury. So the body starts to do that, that fight or flight response. Except because you have this spinal injury, your fight or flight response is different from top to the bottom. So below the injury, they'll be pale, there'll be no sweating, very cool. Above it, you're gonna have increased heart rate, sweating, right? That traditional fight or flight. This can be caused by restrictive clothing or a pressure ulcer or overfull bladder, UTI, a number of different things that can really irritate um, the paralyzed portion of the body, right? Because the body's still kind of picking it up, but you can't do anything about it. UTIs and sepsis, especially urosepsis, is very common. Depending on the height of the spinal injury, respiratory infections can also be an issue. Um, Random injuries because they didn't feel it, possible. Anxiety disorders are very common these days. People seem to be very, very, very stressed, very anxious about stuff. Um, I'm gonna blame social media, but anyway, um, sometimes it's hard to tell the difference between run-of-the-mill anxiety and an actual medical problem. So sometimes it's easy, sometimes it's not. If you're in any way, shape, or form unsure if it is fully just anxiety, do a full workup. What was it to you? 5 minutes? 5 minutes of your time? Do the full workup. Don't let anybody, you know, be like, well, it's just anxiety. Maybe it's not. Maybe today's the day. Um, a lot of times anxiety is associated with chest discomfort, tachycardia, tachypnea, right? They can throw off their acid-base balance so badly that they syncopize. All of these are possibilities. Mental illnesses, right? You can have biologic or trauma caused, psychosocial, right? Caused by abuse and neglect, social, cultural, um, brought to you by interpersonal relationships like, potentially abuse and whatnot. Um, Mental health disorders tend to have a diagnosis peak at around 19. Okay. Certain disorders can be picked up younger, but a lot of the times things like schizophrenia, bipolar, etc., start to kind of show their face in the teen years when you have that swing of hormones going on. Okay. The problem with mental health issues in the United States is we don't talk about mental health issues. We don't believe that they're a thing. So substance abuse becomes a huge issue. A lot of the times, patients who have depression also have bad anxiety. Okay, they tend to kind of go hand in hand. So you just want to make sure that you do a good workup. Developmental disabilities, right? The brain has, in some way, shape, or form, not developed properly, which means that the person is not able to learn at the usual rate. Maybe they don't have good language skills, or they're not age appropriate in their milestones. And a lot of times these get picked up at a very young age, right? Um, could be genetic, it could be due to maternal alcohol, drug use, brain damage before, during, or right after birth. Jaundice is untreated. Like there's a whole bunch of different issues. Genetic chromosomal defects. All of these things can result in a developmental disability, which means that you might have a full-grown person who is at the mental capacity of a 5-year-old, which means that you have to be patient. Okay, so I think the biggest takeaway from this entire lecture is that you should be patient. That's all. Patient. Um, Other things, right? They might have issues with coordination, walking, social interactions, right? ADD, ADHD falls into developmental disability because it's an executive functioning problem, right? A lot of times kids with ADD and ADHD have a hard time seeing the process of what they're trying to do. Okay, so if I say, all right, go make a peanut butter and jelly sandwich, they are not necessarily able to break down that, all right, I need to get bread, I need peanut butter, I need jelly, I need a knife, I need a plate. Okay, so they just see the end product and they're like, oh no, like this is potentially too much. Okay, this happens with some patients with autism as well. Autism and ADD, ADHD are on a very broad spectrum, right? You have very high functioning, or what we call high functioning, which I think is kind of, in my opinion, is kind of insulting. Like we're holding you to the parameters of everybody else in the world, and you're like, but I'm brilliant in certain areas, right? They have once there's some kids who have, or people with autism who have very specific interests, and they are absolutely brilliant at those things, but other things that don't interest them, they don't necessarily want to learn, right? So to say that they're quote unquote high functioning is, as I said, I think that's kind of insulting. Why do the quote unquote normal neurotypical people get to set that bar? Um, Cerebral palsy, hearing loss issues can contribute to developmental disabilities, right? Because they're not getting the stimulation if it's not being treated. Learning disabilities, vision impairment, same. Down syndrome, or also called trisomy 21, which you're going to see that phrasing on any test that you take, um, is a genetic disorder, right? They have a third 21 chromosome, a 21st chromosome, and they have very specific characteristic physical appearances, right? A very small face and facial features, kind of upslanting eyes, smaller ears, a larger tongue, maybe very like short and broad hands. Almost, Fortunately, about half of kids born with Down syndrome are also born with a heart defect. Um, C1 and C2, your atlantoaxial location, right? The atlas and the axis, right? Those C1 and C2. There's a lot of instability right there. So if a patient with Down syndrome is involved in a trauma, a car accident, anything like that, they have an increased risk of cervical injury. So always keep that in mind if you're treating someone with Down syndrome. Other issues, right? They have that larger tongue, so they have an increased risk for airway obstruction. And just because of their genetics, they have a lot of increased risk for issues such as early onset menopause, obesity, diabetes, musculoskeletal problems, all the not wonderful kind of things that we see. Intellectual disabilities, right, is ability to learn, adapt socially is significantly limited. Most of the time, this is seen before the age of 18, and this also can be brought to you by a variety of different issues. So it could be genetic, right? The Down syndrome could cause serious intellectual disabilities. Um, it could be birth defects, fetal alcohol syndrome, meningitis, um, malnutrition, abuse, just full-blown neglect in infancy where the kid's just not being stimulated and that neuroplasticity never gets a chance to really thrive. Cancer, cancer's bad. Cancer's no good. A whole bunch of people get cancer every year, and we're still kind of futzing our way around actually finding solutions. Signs and symptoms of the issue is usually dependent upon the type of cancer. I will say the bigger problem, the 50-50 bigger problem, is going to be the side effects of chemo and radiation. Okay, chemo and radiation is very toxic to the body, which is why we're using it against cancer, right? We're trying to kill the bad cells, but there's side effects beyond like, oh, you lost your hair kind of thing, right? Fatigue, pain, um, calcium. Okay, a lot of chemotherapy will actually leach calcium out of the bones and out of the blood. So you have patients who are hypocalcemic and having like really wild um, cardiac dysrhythmias. Okay, increased risk of blood clotting, right? This is why their metastatic cancers are increased risk for PE, not only because of blood clotting, but hey, maybe there's a little chunk of tumor floating around in your body somewhere. All right, so altogether, cancer sucks, and you're probably going to end up seeing it. Ask your patient as many questions as you can about what their experiences are, because that's going to probably give you the most clue. Cerebral palsy is a non-progressive disorder. It's caused by muscle spasticity and other movement irregularities. Okay, it could be caused by any sort of fetal or infant development disturbances. It could be due to birth trauma and infection, fetal hypoxia, right? This is why they watch those decelerations and stuff so carefully. Any sort of brain malformation. It's dependent on the functional level. Some kids are much more seriously impaired than others. Okay. Cystic fibrosis is a widespread syndrome. We kind of traditionally think of it as very fluid in the lungs all the time, but it also affects the GI system. There's extremely high levels of mucus in the GI system, and it starts to kind of clog up the pancreas and the liver as well. Sweat glands, so they'll have very unique sweating, right? Is caused by a gene that encodes CFTR protein. So there's just a whole number of things that are kind of associated with cystic fibrosis. The For the most part, there's also again a range of severity for cystic fibrosis. The most common treatment for severe cystic fibrosis is a double lung transplant. Okay. I did learn that apparently, so cystic fibrosis is a recessive genetic disorder, which means you have to get the gene from both of your parents in order to have cystic fibrosis, like the worst birth gift you could ever get. But if you carry the recessive gene, you can have some symptoms of cystic fibrosis, like the persistent cough and like some like lung infections and stuff. And like you'll never necessarily even know that you are a recessive genetic carrier of it. It pops up every once in a while in genetic testing when people are doing family planning. So the glands in the lining of the bronchi retains too much sodium and chloride. Where sodium chloride go, water goes, creates that mucus. Pancreas has a hard time breaking down the fats, making enzymes to break down fats. So you have unfortunate looking stools, right? They're very smelly, greasy, because the fat's not breaking down. Productive cough, like regular lung infections. A lot of patients who have cystic fibrosis will have this pulsating vest. Okay, and it constantly moves the mucus in their lungs so it doesn't get like cement and helps them bring it up regularly. A lot of times these patients might have home oxygen therapy, Okay, they're on a slew of medications to try to keep their disease in check until they can get a lung transplant. Previous head injury or TBI, traumatic brain injury. Again, this lives on a continuum. So you could have a concussion with almost no issue, or you could have a severe TBI where there's language communication issues, memory issues, now new learning issues, um, ambulatory issues, right? Could, again, huge range of symptoms, signs and symptoms that could be um, affected. Um, if the frontal lobe is affected, usually it ends up with personality changes, focused issues. Various body parts are controlled by the frontal lobe. The parietal lobe on the side. Hard time with language, speech and language is usually in the parietal lobe. Math skills is also in there. Hand-eye coordination. Occipital lobe right here in the back. Vision issues, hallucinations, again, things that are associated with vision. Temporal lobes on the side, difficulty recognizing people's faces, loss of time. There was a woman who had a temporal lobe injury who was decided after she had it that she was going to be an ultra runner because she had lost her concept of time. So she would go out for a run and she'd come back like 7 hours later and not know that she had been gone for 7 hours because now her body just doesn't feel that level of fatigue because she doesn't have a concept of time anymore. Brainstem, right in the back. If the brainstem is injured, usually you're not doing really well at all. But if you make it through, you might have difficulty swallowing, organization, balance and movement, right? We're moving into this finer motor skills, especially the cerebellum, right? Very fine motor movements, walking, dizziness, slurred speech, okay? Don't be an asshole. There you go. Culture diverse patients. Um, there's a lot of hot button topics right now about cultural diversity, okay? Again, just don't be an asshole. Pretty simple. Um, don't be judgmental. Like everyone has their own experience, and their experience is better or worse than yours. It's their own. They probably have experienced things different than you. Um, a lot of times we anticipate people to have the white Christian male experience, and that's not the same for everybody. So, um, I work in Queens primarily. One of the this is a little bit old, so it might have changed a little bit, but there are, I believe it's 117 different cultures represented in Queens. Queens is the most diverse location in the world. Okay. But the city as a whole is also extremely diverse. So depending on where you work, you should be familiar with the cultures that you might encounter. Okay. Unless you're in Breezy Point, white. So again, everybody's got a number of different, cultural backgrounds, ethnic backgrounds that they come from. Don't be an asshole. Um, you don't have to agree with what their cultures and what their beliefs are in order to be a good healthcare provider. You might have some stumbling blocks, right? Especially depending on if you're dealing with some conservative religions or conservative cultures that have issues with, cross-gendered care. Um, or there's some religions that don't necessarily believe in various aspects of healthcare. So again, you don't have to agree with it, but you have to present them the information and allow them to make their decision. Sometimes you might, if it's a life and limb situation, you might have to be um, a little forceful in determining what's going on or how to proceed. um, but respect other people's experiences and what their beliefs of health and illness are, right? Asian cultures, right? They usually will try their home remedies, and they will very rarely call 911 until they're like death's door, right? They're good. That's just their culture. That's how they do it. You know, the Spanish cultures love their Vicks. The Guyanese culture is the same thing with Lamicol, right? They have their own home remedies. It's going to be different. You're going to be in places that seeing cultures that are not yours, and that's okay. It just makes you a more well-rounded individual. Um, Financial challenges. All right, right. For some reason in this country, we just refuse to allow people to have health insurance. We immediately tie it into it's a perk of your employment, which if you own your own business or you're currently unemployed or you're between jobs, that doesn't mean that your health, you know, should take a serious back seat. That means that, I should stop getting my insulin because I'm transitioning jobs or I'm moving across the country or any other number of stupid things that we do here. Um, so what happens is this falls a lot onto the 911 system. Through the Affordable Care Act, we saw a massive influx in New York City, the number of people using 911 to receive primary care, okay, to go to the ER. And again, this is a much bigger problem in states than just like, oh, well, you don't have health insurance. Our ability to try to fix that for people, get people going on about the socialized healthcare. Like, how about you just make sure that healthcare is affordable? Capitalism doesn't have to touch every aspect of our lives. Poverty, same thing, right? Poverty is a huge concern. It causes a lot of not only health issues, but educational issues, child development issues, crime. It's a big problem. And again, this is something else we aren't really dealing with well in this country. Um, and I see a lot of people who work in the system long enough start to kind of get a little burnt out and crispy around people who, you know, maybe come from a poverty background. It's not necessarily that they want to be, homeless. Something's Sometimes things just happen, right? Don't start thinking less of. There's a lot of people who are homeless who've got some pretty fascinating life stories that you wouldn't, expect them to be homeless. Sometimes people's luck just turns. A lot of problems with homelessness other than being exposed to the elements. Poor hygiene overall, right? We like to be clean. Chronic illnesses, poor nutrition, a lot of respiratory tract infections, trauma, a lot of violence against homeless people, not just on the streets, but in the shelters as well. So, it's a huge public health concern that we aren't addressing. Um, chronic users, right? The frequent flyers are high system utilizers. Um, a lot of the times it's older adults who are trying really hard to not, be put into a nursing home. Patients who have been recently discharged, patients without, appropriate resources. It might be they don't have a family support system, or they um, aren't able to take care of their needs well, or hey, maybe they, are homeless alcoholics. There's a lot of people who you're going to kind of end up seeing a lot over and over. It happens. Most of the time, high system utilizers are male between the age of 40 and 60, homeless, with history of alcohol abuse and a behavioral issue. Um, Mobile integrated health, okay, aka and/or community paramedicine, is this new push that we're trying to kind of put into place in order to help these patients a little bit better, maybe get them to the resources that they need, social work, maybe bring them to an alternative destination like an urgent care or a shelter or something else in particular. The problem is a lot of these um, programs are very regional and there's no standard across the board, and it's something that like you can't bill for yet. So if you can't bill, it means you can't necessarily pay for it. So having a mobile integrated health system is a challenge unless you can figure out a way to pay. All right. Questions, thoughts, concerns? I'm assuming the beach is Beth. Beth isn't here, but her beach is. Thanks, Beth. All right, y'all. There's Beth. Hi, Beth. All right. So if you don't have any questions about my day, I hope you all have a lovely day. I apologize again for the late start. Uh, my morning went from being free to being full of meetings. Um, I'm gonna go take an aspirin.
That bad, huh?
I just got this like headache right here. So, all right, guys.
In case you didn't notice, we lost one more and Vinny's gone. So
What? Why? What happened?
his to tell. I'm just letting you know he's gone.
Wow.
I heard a story, but I'm not gonna say anything.
There you go. The story for the ages. Let it live in infamy or legacy. Whatever.
Oh my gosh.
Hey, it's not you. Keep on trucking. All right, guys. I don't know if this test is done, if this is available. I'll give it a look. But
I have a question. What do
go
you
ahead.
think they're gonna focus on? Like, what chapter? Because it's so random. I'm like,
We read 5
Which chapter?
chapters and they only focus on 2.
yeah, I know.
All right. I literally I wish I could tell you, but I'm pretty sure there's just a hold on.